Hello and a very warm welcome to all of you. I am Dr.Anumita Chatterjee, practicing pediatrician from Shiliguri, West Bengal. I hope you're all in good health and taking care of yourself. Today, we are going to study about pediatric urinary tract infections or pediatric UTI, which we come across very commonly and is an important problem that we need to handle properly because if not evaluated at the right time, or if not rapidly evaluated, then it can lead to renal scarring and many other complications. So the objectives of this presentation are firstly to define a UTI, list the antibiotic treatment options that are now available for UTI, list the workup after a first febrile UTI, and what are the investigations and how we are supposed to treat febrile UTI, and to look for recurrence and breakthrough UTIs, to study the complications of UTI, and be familiar with the rationale for using prophylactic antibiotics after the first febrile UTI. So now, UTI is a common bacterial infection in infants and children. It occurs more commonly than we give it credit for. It occurs quite commonly, and basically the diagnosis is important. And for us pediatricians to identify urinary tract infections and to treat it is very important. So basically it's a common bacterial infection which occurs both in neonates, infants and children. And the risk of having a UTI, however, before the age of 14 years is approximately 1 to 3% in boys and 3 to 10% in girls. So it's almost double to triple in girls. It's more common for girls to catch a UTI as compared to boys. And rapid evaluation and treatment of UTI is important to prevent renal parenchymal damage and renal scarring, which can cause hypertension and therefore progressive renal damage, and endpoint CKD. Now, coming to the epidemiology, the overall prevalence of UTI is approximately 5% in case of febrile infants, but varies widely by race and sex. Caucasian children had a 2 to 4-fold higher prevalence of UTI as compared to the African American children. And females have got a 2 to 4-fold higher prevalence of UTI than do circumcised males. And Caucasian females with a temperature of 39 degrees Celsius have a UTI prevalence of 16%. Up to 7% of the girls and 2% of boys experience a symptomatic culture-proven UTI prior to 6 years of age. And of febrile units, up to 7% usually have UTI. Now coming to the definition. Basically, the definition of UTI is done in two ways. One is based on the culture positivity, because culture is an absolute and very important part for diagnosis of UTI and establishing UTI, and also based on the symptomatology along with the bacterial presence in the urine, or along with the culture results also. So based on the clinical symptoms as well, there is definition of UTI. So basically, urinary tract infection is identified by growth of a significant number of organisms of a single species in the urine in the presence of symptoms. So it has to be a single species in the urine. Okay, and there are certain periurethral flora species which are the common species of urine itself. So if it is the positivity of those pathogens, then it is not UTI. Now, diagnosis of UTI has to be patients with a positive urine culture. So urine culture is a must for the diagnosis or for establishing a urinary tract infection in pediatrics. Now, there is also something called recurrent UTI, which is defined as the recurrence of symptoms with significant bacteriuria in patients who have recovered clinically following treatment. It is again more common in girls, and recurrent UTI usually adds to parental anxiety, medical costs, and the risk of renal parenchymal damage in young infants. Also, recurrent UTI is a flag bearer towards bladder bowel dysfunctions, or it is in case of boys, it is also a sign of an underlying vesicoureteric reflux. Now coming to the definitions, this is based on the findings in our urine specimen. the number of bacteria in our urine specimen. So firstly, significant bacteriuria. It is the colony count of more than 10 to the power 5, that is 1 lakh per ml of a single species in a midstream clean cat sample. Each word is important. So this is colony count, the number, single species. It has to be a singleton species, and the way of collecting the urine specimen is also important. It is a midstream clean cat sample. Okay, because different ways of collecting the urine specimen has a different count of bacteriuria that is to be taken as significant. Right. So now asymptomatic bacteriuria is significant bacteriuria in the absence of symptoms of urinary tract infection. Simple UTI. When there is UTI with low-grade fever, dysuria, frequency, and urgency, and absence of symptoms of complicated UTI. So basically, simple UTI is actually the absence of symptoms that mark complicated UTI. Now, for that, we have to see what is complicated UTI. So complicated UTI is very specific things like presence of fever, high-grade fever, that is more than 39 degrees Celsius, systemic toxicity, persistent vomiting, dehydration, renal angle tenderness, and raised creatinine. Now, why do we have to define these symptoms? It is because in case of pediatrics or in case of children, they do not have clear-cut or clearly demarcated symptoms of fever, abdominal pain, or dysuria or burning micturition all the time. A child is not able to clearly complain of these things. It is rather a much subtle presentation in children. Maybe the child, a child more than 1 year of age is continuously crying while passing urine, or is holding the abdomen and sitting, is not able to pass urine, or is hesitant to pass urine, right? So there is urgency, but the child is still not able to pass urine. It is these subtle symptoms that parents or doctors have to pick up. It is as a child is not able to tell it properly. Whereas in case of adults, there are clear-cut demarcated symptoms. So that is why, first of all, the symptoms are quite subtle, which we have to catch, and it becomes further a more difficult job for the pediatricians, and a further more important job, because if we are not diagnosing UTI at the right time, it could be a flag bearer or a sign of vesicoureteric reflux underlying, or any other bladder bubble dysfunction, or any other renal parenchymal damage, which can further lead to renal scarring, and alas, we have lost a kidney. Now, so once again, complicated UTI is high-grade fever or fever more than 39 degrees Celsius with other symptoms of systemic toxicity, persistent vomiting, dehydration, renal angle tenderness, and raised creatinine. And the absence of these symptoms with just fever is with low-grade fever is simple UTI. Now, recurrent infection is the second episode of UTI after a child has recovered from the first episode with full treatment. Now, coming to the clinical signs and symptoms. So, as I was telling, the signs and symptoms are quite subtle, and they will differ as per the age group. As in case of children who are less than 2 years old, or it will be fever without a focus, just a fever. So the most common cause of only fever occurring since a few days, we have to think of UTI. Apart from cold, if there have been no symptoms like cold, cough, etc., or any symptoms of symptoms of upper respiratory tract or lower respiratory tract, then just a fever, we have to think in terms of UTI. Then in neonates, UTI is usually a part of septicemia, a bigger infection, a broader systemic infection. So there will be fever, the baby is not taking feeds, lethargic, vomiting, jaundice, and there can be seizures as well. Now in infants and younger children, there is recurrent fever, diarrhea, vomiting, abdominal pain, and there can be poor weight gain as well. If there is usually recurrent UTI, then children tend to have poor weight gain. In case of older children, they will be able to tell their symptoms better. So there will be again fever. Fever is the common symptom that is present in all the age groups. But with that, there will be dysuria, urgency, and frequency. and along with that, abdominal or flank pain. So there will be better presentation of dysuria or burning micturition. They are able to elicit urgency and frequency, but not able to pass the urine. And adolescents can have symptoms restricted to the lower tract, and fever may not be present. Usually, a differentiation between upper tract infection and lower tract infection is not all that necessary in case of children, because treatment, first of all, is the same. That is, we are going to start with antibiotics. And another thing is that we are more concerned, and if a child is eliciting any symptoms, or there is a culture showing pathogens positive or bacteriuria, then we are more concerned, or we will treat it as an upper urinary tract infection, because we are more concerned about renal parenchymal damage or renal scarring. So that is why upper urinary tract infection is more important and is of more significance in case of pediatrics. So therefore, there are features also which suggest underlying structural abnormalities like a distended bladder. This, however, is more common in case of neonates, or palpable enlarged kidneys. A tight phimosis or vulval synechia might be present. Then usually constipation in children is a very common cause of bowel bladder dysfunction and is usually associated with UTI. Both constipation and diarrhea in children can be associated with UTI. So when we are treating constipation, we have to check for urinary samples and rule out the UTI in these children as well. Then tight phimosis, palpable fecal mass in the colon, patulous anus, or neurological deficit in the lower limbs. Then if there has been any urinary incontinence, again, in case of spinal lesions, that can be there, or in acute flaccid paralysis or so. Then previous surgery of the urinary tract, anorectal malformation, or in case of a meningomyelocele. Then there could be features suggestive of bowel bladder dysfunction, like recurrent urinary tract infections, as I have already said, can be related to bowel bladder dysfunction or because of an underlying vesicoureteric reflux. Then constipation and impacted stools, maneuvers to postpone voiding. These are the holding maneuvers, that is Vincent curtsy or squatting. That is, the child out of embarrassment might just go to one corner of the house or one corner of the room, and this is a curtsy. Basically, they try to bend down, holding their genital, tightly pressing their genital area so that they can prevent the urine leak. Because this is basically a sign of urgency. They have urgency, but they are unable to pass, or when they will pass, they will have a lot of pain. So they just try to hold the urine in that manner. Then voiding less than 3 or more than 8 times a day, straining or a very poor urinary stream, thickened bladder wall more than 2 millimeters on ultrasound, post-void residue of more than 20 ml, and spinning top configuration of bladder on MCUG. So this diaper, if we look at it, it looks like probably it's a neonatal hematuria, but no, it's uric acid crystals. Now coming to the diagnosis and evaluation, it's based on positive culture of properly collected specimen of urine. So UTI in children is completely and specifically defined in terms of a positive culture that is obtained from properly collected, that is a properly collected urine sample. It could be a midstream urine sample or a suprapubic aspiration or a bag sample. Now, I'm sorry, catheter sample, bag sample not good enough. So as per our pyuria or the presence of leukocytes also, it is defined. So significant pyuria is defined as more than 10 leukocytes per millimeter cube in a fresh uncentrifuged sample, or more than 5 leukocytes per high power field in a centrifuged sample. So this is quite a common question in case of clinics as well. In the uncentrifuged sample, it is more than 10 leukocytes, whereas in case of centrifuged sample, it is more than 5 leukocytes per high power field. Then leukocyturia might occur in conditions like fever, glomerulonephritis, if there are already renal stones or presence of any foreign body in the urinary tract. And the detection of leukocyturia in the absence of significant bacteriuria is not sufficient to diagnose a UTI. Now coming to diagnosis and evaluation further, apart from pyuria as well as bacteriuria, in the urine specimen or urine evaluation or in urine cultures, there are rapid dipstick based tests as well, which detect the leukocyte, esterase and nitrite and are again useful in screening for UTI. The combination of these tests has moderate sensitivity and specificity for detecting UTI and is diagnostically as useful as microscopy. But however, we still rely most on the culture itself. So now coming to a very important thing, that is collection of specimen for culture. Now this has to be communicated between the doctor and the parents of the child, because it is ultimately the parents who are going to help the child collect the specimen. And if a specimen is not collected properly, then also it loses its potential to diagnose it. So basically, we are going to take a clean catch. Midstream specimen is taken. And first, the genitals have to be washed with soap and water. Antiseptics is discouraged. We don't use antiseptics. And this cleaning is basically to avoid any periurethral flora contamination of the sample that we are going to take. So in neonates and infants, suprapubic aspiration or transurethral bladder catheterization is done. And both of these procedures are simple. And of course, these are a very good sample for the detection of organisms. And the urine sample has to be promptly plated within 1 hour of collection. If there is any sort of delay, it has to be refrigerated at 4 degrees Celsius for up to 12 to 24 hours. And urine bag specimens have got a very high false positive rate. It's not collected also properly, unsterile techniques, and therefore it's not recommended much. The few times when urine culture repeat is recommended is when a case of contamination is suspected, which we can know by if the urine sample has grown 2 microorganism species, or it is common species which are found in the found as periurethral flora. For example, in case of young girls, it is lactobacilli, or in case of infants, it could be enterococci. Or if the UTI is strongly suspected, but colony counts have come equivocal, that is less than 10 to the power 5. Now, coming to the strict criteria for diagnosis, this is a very important slide. We have to remember this because based on this, the diagnosis of UTI present or not present is made. So basically, if it is a suprapubic aspirate that has been collected, then any number of pathogens is suggestive of UTI, is diagnostic of UTI. If it's a urethral catheterization sample, then it has to be more than 5 into 10 to the power 4. That is 50,000 colony forming units per ml. And in case of midstream clean catch, it is more than 10 to the power 5 CFU. That is more than 1 lakh sample, 1 lakh colonies is suggestive of UTI. Now coming to urine dipsticks, in a cohort study with an 18% baseline prevalence of UTI, negative leukocyte esterase and nitrates on dipstick have got a negative predictive value of 96%. And leukocyte esterase and nitrites, LE, is produced because of the breakdown of leukocytes. So it's not always indicative of infection, because we've seen multiple conditions like fever, excessive exercise, or in case of renal stones also, leukocytes can be physiologically present in the urine. So just that will, so therefore just leukocyte esterase will not be indicative of infection. Vaginitis and vulvitis can also lead to inflammation without any infection, and that will lead to a positive leukocyte esterase. Now, nitrites are produced by bacteria that metabolize nitrates. So that is basically the gram-negative ones like E. coli, Klebsiella, Proteus, and therefore nitrites are much more predictive of UTI. And GPCs, that is gram-positive bacteria, do not produce nitrites. Now coming to blood cultures are usually unnecessary. It is urine. UTI is one infection where establishing a local infection or establishing the local cause or the localizing of fever becomes easy, because urine cultures and urine evaluation both are quite efficient if the specimen is collected properly. So therefore, in case of UTI, we don't usually have to go till blood cultures. They are more frequently positive in children younger than 2 months whose urine grows group B streptococci or Staph aureus. And in general, we'll just send febrile children less than 2 months old to the ER for emergent evaluation. Now, coming to treatment, first of all, the immediate treatment. Now, because of UTI, or in cases of complicated UTI, the children might have symptoms which are suggestive of extreme dehydration, severe toxicity, systemic involvement, very high-grade fever, and uh, therefore, that can lead to need of hospitalization. So need for hospitalization depends upon the patient's age. It's moreover required in case of neonates and younger infants, because neonates, usually UTI is also a part of septicemia, we have to remember. Then if there are any features suggesting toxicity, dehydration, and ability to retain oral intake, or the likelihood of compliance with medication is not there. So basically, our entire therapy aims to reduce the morbidity of infection, to minimize renal damage to detect it early and therefore stop UTI and its recurrence, and further renal parenchymal damage at an early stop, and any basically subsequent complications are meant to be reduced. So children less than 3 months of age and those with complicated UTI have to be hospitalized and treated with parenteral antibiotics. Usually a third generation cephalosporin is preferred, and therapy with a daily dose of an aminoglycoside may be used in children with normal renal function, but cephalosporins are considered safe. And we basically modify the treatment based on the result of antimicrobial sensitivity. And IV therapy is given for the first 2 to 3 days, followed by oral antibiotics once the clinical condition improves. So now coming to the antimicrobials or the antibiotics for the treatment of UTI. So this list is the antibiotics which we are going to use for treatment. There is a separate list which I will be coming to later, which is used for the long-term prophylaxis. So for treatment, as I said, a third generation cephalosporin is the best. And the best point is that we've got oral as well as parenteral cephalosporins. So firstly, the parenteral ones, it is ceftriaxone, cefotaxime, that is used at these doses. And as aminoglycosides, we can use amikacin or gentamicin. Also, coamoxiclav acts excellently in case of UTI. And for oral, we have again cefixime, coamoxiclav, some cases ciprofloxacin, ofloxacin, and cephalexin. Now coming to the treatment of UTIs. So this is again based on the type of UTI, whether it's simple or complicated, whether it's a recurrent UTI, and what is the age of the child, what is the degree of toxicity, and other clinical or systemic symptoms that are associated with UTI. So children with simple UTI and those above 3 months of age are treated with oral antibiotics itself. It is sufficient. With adequate therapy, there is a resolution of fever and reduction of symptoms by 48 to 72 hours. And failure to respond may be due to the presence of resistant pathogens or a complicating factor or non-compliance. And these patients might require repeat cultures and reevaluation. Now, coming to the duration of treatment. So in case of complicated UTI, the duration of therapy is to be 10 to 14 days for infants and children. For uncomplicated UTI, it could be 7 to 10 days itself. For cystitis, 5 days. And for adolescents with cystitis, may be treated with shorter duration of antibiotics lasting for 3 days. And prophylactic antibiotic therapy, this is important. Following the treatment of UTI is initiated in children below 1 year of age until appropriate imaging of the urinary tract is completed. So usually in less than 1 year of age, if there is UTI, we do start with prophylactic antibiotic therapy and suitable imaging. So supportive therapy, this is mainly associated with the various symptoms that we present with. So we have to maintain adequate hydration. If the child has very poor oral intake or has severe dehydration, IV fluids might also be required. Usually routine alkalization might not be necessary, but during the acute episode of UTI, it's good to do that. Paracetamol can be used to relieve fever, and it also relieves the abdominal pain. Therapy with NSAIDs is not encouraged, and we have to repeat urine culture if there is persistence of fever and toxicity despite 72 hours of adequate antibiotic therapy. Next, coming to this important slide, that is the evaluation after the first UTI. This is all these information and all these images and tables are as per IAP guidelines for UTI management. So, why is the first UTI important to us? Because up till 5 years of age, UTI and recurrences of UTI can lead to subsequent complications and long-term complications like renal parenchymal damage. And that is mainly because UTI is basically just a sign, can just be a sign of a vesicoureteral reflux, a megaureter, or any other features or any other things that we have studied in the previous slides, which are related to bladder bowel dysfunction, or any other physical or other visceral uh, uh, or anatomical malformations of the entire urinary system. So, evaluation after the first UTI. When a child below 5 years of age gets first urinary tract infection. So if the age of the first UTI is less than 1 year, then we have to plan all the 3 investigations, that is ultrasound, then a micturating cystourethrogram or MCU scan, and a DMSA renal scan. I will also elaborate what each of the investigation is specifically good for evaluating. If the first UTI has occurred in age group of 1 to 5 years, then we have to do an ultrasound and a DMSA scan. And if the ultrasound or the DMSA scan show any renal abnormality, then we have to go for a MCU. And if the age is more than 5 years, we will only do an ultrasound. And if the ultrasound has come abnormal, then we will go for both MCU and DMSA scan. If the age is I'll repeat once again, if the age is less than 1 year, all 3 investigations. Firstly, the ultrasound, and then the MCU as well as the DMSA scan. If age is 1 to 5 years, we do ultrasound and the DMSA scan. But if at all there is any abnormality in MCU or DMSA, then if there is any abnormality in the ultrasound or DMSA, then we will do an MCU also. And when age is more than 5 years, if the ultrasound is abnormal, then we go for MCU and DMSA scan. So next, coming to the specific things that each of these investigation points out. First of all, ultrasound. Ultrasound helps us to know the kidney size, the number, and the location. If there is any presence of hydronephrosis, any urinary bladder anomalies, the post-void residual urine, and also ultrasound has to be done immediately after the diagnosis of UTI. Next, the DMSA scan. This is a sensitive technique for detecting the renal parenchymal infection and also the cortical scarring. And it is carried out for 2 to 3 months after 2 to 3 months after the treatment of UTI. So DMSA and MCU both have to be done after the antibiotic course for treating UTI is completed. And MCU detects vesicoureteral reflux and provides anatomical details. So broadly, DMSA helps us to know about the renal function, whereas MCU helps us to note any anatomical abnormalities. So provides anatomical details regarding the bladder and urethra, detects vesicoureteral reflux, and usually this is also recommended 2 to 3 weeks after completing the antibiotic therapy of UTI. Now coming to indications and duration of prophylaxis. So prophylactic antibiotic therapy depends on the patient's age and the presence or absence of vesicoureteral reflux. Antibiotic prophylaxis is recommended for patients when a baby has UTI below 1 year of age. First episode of UTI has occurred below 1 year of age while we are awaiting for imaging studies, or after imaging studies, we have ascertained that the child has got vesicoureteric reflux, then this antibiotic prophylaxis has to be continued till 5 years of age. And in case of frequent febrile UTI, that is if febrile UTI 3 or more episodes in a year have occurred, or then even if the urinary tract is normal, we are going to continue the prophylaxis till 5 years of age. And antibiotic prophylaxis is not advised in patients with UTI with posterior urethral valves or urolithiasis or neurogenic bladder, and in patients on clean intermittent catheterization. So now the antibiotics that we used for prophylaxis of UTI. So this is cotrimoxazole, which is used in 1 to 2 mg per kg per day. This is available as a syrup in in a syrup formulation. So it is avoided in patients less than 3 months of age and in cases of G6PD deficiency. Then we have nitrofurantoin, which is given as 1 to 2 mg per kg per day, which can cause vomiting and nausea. So again, avoided in patients less than 3 months of age and G6PD deficiency or in case of renal insufficiency. And others are cephalexin, which is given as 10 mg per kg per day, which is the drug of choice in case of first 3 to 6 months of life. And cefadroxil can also be used. Now coming to vesicoureteric reflux. So VUR is seen in 40 to 50% of infants and 30 to 50% children with UTI, and it resolves with age. Its severity is graded using the International Study Classification from grade 1 to grade 5 based on the appearance of the urinary tract on MCU. The lower grades of reflux are grades 1 to 3 and they are more likely to resolve. And secondary VUR is often related to bladder outflow obstruction, as with posterior urethral valves, neurogenic bladder, or a functional voiding disorder. So moderate to severe VUR, particularly if bilateral, is a very important risk factor for pyelonephritis and renal scarring. So this is what I was talking about throughout. With subsequent risk of hypertension, albuminuria, and finally progressive kidney disease. It can even progress to CKD as well. And risk of scarring is usually highest in the first year of life. So presence of intrauterine VUR has been associated usually with renal hypoplasia or dysplasia. Now coming to the treatment, it is recommended initially to receive antibiotic prophylaxis while awaiting spontaneous resolution of VUR. Close follow-up is required for occurrence of breakthrough UTI, and we have to repeat the imaging every 18 to 36 months in patients with grade 3 to 5 VUR. And radionuclide cystogram with low radiation exposure has higher sensitivity for detecting reflux and is therefore preferred for follow-up evaluation. So this is the management in case of VUR grades 1 and 2. Antibiotic prophylaxis is given until 1 year old. We restart the antibiotic prophylaxis if breakthrough febrile UTI is there. In case of grades 3 to 5, the antibiotic prophylaxis has to be covered up to 5 years of age, and we have to consider surgery if there is breakthrough febrile UTI. That is, in spite of taking prophylaxis, because of non-compliance, there is still febrile UTI. And beyond 5 years, prophylaxis is continued only if there is bowel bladder dysfunction. So even if there are children who have got mild to moderate VUR and more than 5 years of age, the prophylaxis is discontinued because usually the Chances of scarring or further renal parenchymal damage are highest or are present only till 5 years of age. It decreases much lesser more than 5 years of age. So that is what, how long to continue antibiotic prophylaxis. We discontinue the antibiotic prophylaxis in children older than 5 years who have got normal bowel and voiding habits, even if there is mild to moderate reflux persisting, because the chances of further renal parenchymal damage or scarring is much lesser after 5 years of age. So patients with grade 3 to 5 reflux may be offered surgical repair if they have started getting breakthrough febrile UTI, or if the parents prefer surgical intervention to prophylaxis, or in patients who have showed a deterioration of renal function. An evaluation of voiding dysfunction based on history, voiding diary has to be done before the surgery, and antibiotic prophylaxis has to be continued for 6 months after the surgical repair is done. Availability of dextranomer or hyaluronic acid copolymer, that is deflux endoscopic treatment, has also been started, but it is still not the first line. Now, since BUR has got familial association, therefore screening of siblings and offsprings is very important, because the reflux is inherited in an autosomal dominant manner with incomplete penetrance. So 27% siblings and 35% of the offsprings might show BUR. And therefore, ultrasound is recommended to screen for the presence of reflux. So this is our ultrasound showing hydronephrosis with dilatations of the renal of your I'm sorry, showing dilatation. So these are the things. And then bowel bladder dysfunction. It's usually associated with a voiding disorder. It's characterized by abnormal patterns of micturition in presence of intact neuronal pathways without any congenital or anatomical abnormalities. Usually, abnormal bladder pressure and the urinary stasis predispose these children to recurrent UTI. And there may be an abnormality either during the filling phase, as in overactive bladder, or in the evacuation phase, as in case of dysfunctional voiding. Now, since constipation is often associated with a functional voiding disorder, the condition is referred to as bowel bladder dysfunction, and evaluation for a voiding disorder will include recording of the frequency and voided volume and fluid intake for 2 to 3 days, and urodynamic studies. The management for bowel bladder dysfunction, if it's an overactive bladder, we give anticholinergic medications like oxybutynin, whereas in case of bowel bladder dysfunction and large post-void residues, we benefit by timely voiding, bladder retraining, and clean intermittent catheterization. So this is a normal VCUG, which shows the urinary bladder and urethra showing the dye, whereas this is vesicoureteric reflux. It shows the entire ureter dilatation of the renal parenchyma or the renal calyces. Up till the calyces, there is dilatation. Now, indication for referral to a pediatric nephrologist. What are the certain conditions where we have to finally refer the child? So that is in case of recurrent UTI or UTI in association with bowel bladder dysfunction, or a patient with vesicoureteric reflux. If there are underlying urologic or renal abnormalities, and if there are children with renal scar, deranged renal functions, and hypertension, in order to take care of AKI and CKD. Thank you.